So this is cholinesterase inhibitors. This is a really old thing from 2003. And when it first came out, one of the things that people found was that it reduced psychomotor agitation and aggression, and it reduced the need for antidepressants, anti-anxiety, and antipsychotics. This was a systematic review of evidence from about an 8 or 9 year period of multiple different things. And what they found was there was some evidence for antipsychotics to be helpful. There was moderate evidence for atypical antipsychotics to be helpful. There's really little to no evidence that antidepressants help anybody who has dementia with behavior disturbance. Mood stabilizers, in fact, not only don't help, they harm. They increase brain atrophy. So there are, if somebody has a manic-like presentation and where their symptoms really look like they're having a manic bipolar type episode, that's the one little group where you might want to use a mood stabilizer, but otherwise, no. There are 8 studies with cholinesterase inhibitors and in this 9 year period, and they showed consistent, modest benefit. So it's a benefit. What gets benefited? Well, here's donepezil. So delusions, apathy, aberrant motor, rivastigmine, irritability, aberrant motor, apathy, hallucinations, nighttime behavior. Rivastigmine, it turns out in this study, which was small and it was open label, so everybody knew who was taking what, so that often influences outcomes, especially if you happen to be paid by a drug company. These people weren't, but so 650 people, they had mild to moderate Alzheimer's disease. They were already on lots of other meds. They were put on rivastigmine and then followed up 4 to 6 months later. And what they found was, so that big column, those are the people who were able to stop or decrease antipsychotic use or anxiolytic use, almost 60% of people. Now, 35% of people or so, there was no change in their dose. And there were a few people who continued to get worse and needed increase in one or both of those medicines. So, study, blah, blah, blah. So, and then there's also evidence for the use of cholinesterase inhibitors in Parkinson's disease dementia and Lewy body dementia. So what do we know? There's several studies, and they show people who have more severe behavioral problems are more likely to benefit from cholinesterase inhibitors. Interestingly, visual hallucinations predict a better behavioral response and possibly a better cognitive response. And if people get a cognitive improvement, so that's that memory, executive functioning, it doesn't relate to whether or not they get a behavioral response. The cognitive benefits of cholinesterase inhibitors, about 10% of people will get that. Not everybody, not even most people. But behavioral responses, most people will get. Blah, blah, blah. Okay, so in your handout, there's the Canadian, so old treatment guidelines didn't recommend the use of dementia-specific medicines in Alzheimer's or anything else. But as more evidence has accumulated about the behavioral improvements that you see with these medicines, newer guidelines from 2012 and 2015 do. And so it's in your handout. These are slides about it. And the European Academy of Neurology last year came out with an article about using combined treatment. And what I want you to notice is the quality of evidence was high for behaviors. So if somebody wants to know about what medicines for behaviors, these are the medicines that I want you to think about first. So what is behavior disturbance? So the NPI has 10 categories, I think, on it, and these are the categories. And I want you to notice the first column of numbers is how many people at any point in their dementia had this, and the second one is how often in the last month did people have this. This is one study, so it's one group of people. But delusions are really common. Agitation and aggression is really common. Apathy is the most common behavioral disturbance in people who have dementia. Apathy really bothers families. And sometimes it bothers caregivers. And so it bears paying attention to. And it's really common, 3 out of 4 people. Euphoria, you don't see that much. Certainly nobody's ever called me because someone was too happy. Irritability, aberrant motor, sleep disturbance, appetite disturbance. These are all really common. Again, that's why I want you to think of dementia as a behavioral illness. Inappropriate sexual behavior. So more recently, we really look, if you see down on the bottom, we look at inappropriate sexual behavior as intimacy seeking or disinhibited. So, you know, everybody is always worried, understandably, naturally, and appropriately about sexual predators. People who have dementia, being a sexual predator is I personally have only seen one case of it in the 15 to 17,000 people I've treated. I'm not saying it's not out there, but it's really rare. But there are a lot more people who get referred to me because they have what is thought of as sexual disturbance. Why do you treat? I really want you to think about treating and encourage treatment, appropriate treatment of dementia with behavior disturbance. This is just you know, a collection of articles from newspapers. I'm not putting in there the, I don't know, several hundred people who I have personally treated who tried to kill somebody, like smother a roommate or strangle a wife. But these are actually people who killed another person, people with dementia who killed another person, who some of whom had known paranoia, but people were reluctant to treat it with medicines. And I just think that's a tragedy. Staff and family members are in danger. You know, aggression is real, and we need to pay attention to it. And it's not okay to say, well, you work in a psych unit, so of course you get hit. You know, that's really not okay. It's not okay that you act like you're a police officer and you kill somebody who hit you. That's not okay either. But you should really treat it, and treat it before it gets severe. It's real common. And family members don't like it. People who care about people who have dementia don't like it when their loved ones are aggressive or sexually disinhibited. So, the overall framework, which I'm not going to bore you with by reviewing again, but identify and assess causes of behavior. Select your interventions based on your assessment. Apply the interventions, observe, measure, and then monitor the outcomes. And if things are better, you might want to consider keep doing what you're doing. And if things aren't better, go back to the drawing board and reassess. So the most common time to see behavioral problems in people with dementia, and in fact probably people in general, is when their basic needs aren't met. What are basic needs? Well, there's physical needs, emotional, environmental, and social needs. That's sort of one way to look at needs. Adequate pain control. If somebody is in pain and they have dementia and they can't use language to communicate very well, you are not going to, there's no amount of antipsychotic in the world that is going to totally make this person better if you don't address their pain. See, now you're awake. So how do you tell if somebody has dementia? This is actually a scale designed for people with Alzheimer's, but it works for anybody who's not verbal or doesn't have good verbal skills. The PAIN AD scale, PAIN Alzheimer's Dementia scale. So and you look, so breathing, going from normal to noisy and labored. Negative vocalizations, going from none to calling out. Facial expression, smiling and happy to grimacing. Body language. Notice this description of pain in people who have Alzheimer's. Rigid, fists clenched, knees pulled up, pulling or pushing, striking out. So it's really easy to say, oh, I want an antipsychotic for that person because they're aggressive. Well, really look to see, is their PAIN AD score 5 or more? If it is, consider treating pain. What's the downside of treating pain with a low-dose opiate, or if they have good kidneys maybe and they're young, an NSAID like ibuprofen? What's the risk of doing that? Those are not hugely risky things in a controlled environment. Body language, consolability. If somebody is, you cannot console them, that really you should think this is probably pain until proven otherwise. So Shelley was somebody who I met who came to Tuality, and she paced almost, I mean, it was not even, it was almost running. I mean, it was nonstop. It was 19 or more hours a day. She was in the hospital for 68 days. And now she would mutter sort of kind of to herself while she was pacing, and she said things like, he beat me up. She said things that sort of had a mildly paranoid flavor. Everybody was wanting, her family was like, well, we don't know about, she must have been abused earlier in her life. Nobody knows about any abuse in the family, but that's, you know, because she's saying these things. And, you know, the only way to interview her was to sort of jog along next to her, because she couldn't sit down. She wouldn't sit down. She wouldn't sit down to eat. The only way to feed her was to hand her things and walk with her. Give her milkshakes. We gave a lot of milkshakes with a straw. I did all the things, right? So I put her on dementia-specific medicines. I put her on an antipsychotic. We tried an antidepressant. We did everything we could think of, and we really made basically zero, took her off of medicines that probably weren't helping her. Zero, about a zero effectiveness at anything. I mean, she was a touch better, but not much. And then somebody said, well, you know, Shelley was a housekeeper. She was like on her knees scrubbing a school for much of her life. And she probably has osteoarthritis. And because she never puts her feet up, her feet are swollen, and they've gotten to the point where they're getting cracked and bleeding. I think she might be in pain. This was an LPN who said this to me. And I said, great idea. And literally, in 10 days, we turned her around by treating her with some opiates and bowel meds. Now, Shelley would not sit down for more than 5 minutes, and she still walked much of the time she was awake. But it wasn't pacing, it wasn't frantic, she wasn't muttering, she wasn't frowning, and she was dischargeable and could be cared for in a community setting. So I would call that success. So, non-pharm strategies. There's lots of stuff out there. There's little that show long-term efficacy, like after the intervention is done. Now, I am not saying you shouldn't do things. You shouldn't do art things and music therapy and all sorts of things with people who have dementia. I do think you should do I think meaningful goal-directed activity is actually an unrecognized essential human need. And that's why giving people who have dementia clothes to fold, or a wash rag, or having them set the table, you know, giving people meaningful goal-directed activity is really important and really helps them. So I definitely think you should do all of these things. But the thing is, after those things stop, people often have their behavior disturbance reemerges. So the one thing that has been shown to help is caregiver education. Educating caregivers and modifying the environment, which, who does that? The caregivers. So caregivers matter. Now, I would say in your assessment, and this is a person-environment mismatch, and again, I would assert that much behavior disturbance, no matter what the cause, I mean, the etiology, like do they have dementia, do they have delirium, do they have this, that, or the other, much of the time, behavior disturbance is from a person-environment mismatch. Either the environment is too challenging, they have limitations, or they have unmet needs. They're unable to engage and do meaningful things. So, what is caregiver education? Well, you know, educating caregivers. Providing person-specific, you know, learning about the person's life before they got so impaired. coming up with interventions. So one of the people who I met was a retired CEO, and he came to see me, and he was a wealthy fellow. I met with him and with his 2 sons, and it was really interesting. I thought, oh, that's why people shine their shoes. They had really shiny shoes, and there I was with sort of scuffed up shoes. But anyway, that's what I noticed. I don't know what they noticed sitting there with them. And he was an executive, and so they had managed to keep him at home and keep him happy for several years. They had happened upon this. He had a big executive desk. He had an in basket and an out basket. And they literally had pieces of paper with a signature line, all sorts of stuff on them. They just printed out contracts and this, that, and the other. They had this pile of stuff, and he would spend 6 hours a day at his desk taking things out of the in basket, signing on the signature line, and putting it in the out basket. This is a man who could no longer read. He could no longer understand what he read, but he was a retired executive. So just so you know, this is what you want to do with doctors. You want to get them an order sheet. This is not going to work in like 30 years when doctors don't know how to write because they only use computers. But for those of us who learned, who trained in the old days, you want to give them an order sheet and say, Doc, so-and-so's got pain, and they'll write. And at some point it'll be a scribble, right? But still, meaningful goal-directed activities. So, blah, blah. Caregiving, communication, person-centered. Touch is important. One of the saddest things about being older in our world is that nobody will touch you once your spouse dies, and that's really not healthy. And being touched, healthy touch is an important part of life. Look for nonverbal communications. And the other thing about this is, so when you have somebody who says, and this is something that's been said to me, I heard it all night last night, they were raping people in that room next door. So a not successful but common strategy would be reality orientation. Oh no, this is a hospital. They weren't doing that. Just say no, don't do it. You're not going to succeed, right? Here's how I would recommend handling something like that. Oh my, that is horrible. That is terrible. We need to get the police in here. You must be so frightened. Let's figure out how we can fix this. What are you doing? You're entering their world. You're not getting into some argument about whether something happened or didn't happen. I was 100% confident in my staff that this was not happening in my hospital. And nobody else was reporting it, which helps. And, that would be horrible. If you thought that was happening, you want people to be upset about that kind of thing. You want people to take action. So you don't want to discourage appropriate action. So you talk to him. So a similar thing. We had a fellow who was new on the unit, and he needed to leave. He had to go home. He said, my car is out there in that parking lot. Well, his car wasn't in the parking lot. But he said he could see it. He could look out the window, and his car was in the parking lot. So it's actually the same LPN who came up with the pain thing. She went she went around the corner, and she called on the phone, and she said, put Larry on the phone. So we put Larry on the phone because he was getting more and more riled up because he needed to leave because he had to drive home, and his car was right out there, and we were keeping him prisoner. So she gets him on the phone, and he's yelling and screaming, and she says, Larry, I'm calling you from the police department. I hear that there is a stolen car. And he's like, my car was stolen? She's like, yes, that's what I've heard. That's the report. So you need to give me the details. What kind of car is it? What color? How many miles? When's the last time you changed the oil? She's going through all this stuff. And he's answering the questions. And then finally he says, there's really something wrong with you. I'm hungry. And he hung up the phone and he went to eat. Right? So it wasn't about arguing with him about whether he needed to go or where he needed to go or whether his car was there or not car. It was sort of distracting him, responding to the emotions underlying what he was saying. That's what caregiver training can do for you. And that's really key. because it's not about the facts. It's about the person's experience and their emotional experience and what they're feeling. And that's what you want to address if you want to help people feel better. Billy. So Billy is a lady who came from really a great, wonderful assisted living. She'd lived there for many, many years. By the time she came to me, she was mostly nonverbal. She was scratching and biting with care. It was terrible. I mean, she came in, she was in the hospital. We couldn't give her a roommate. She looked terrified. She was about 85 years old. She wouldn't eat, she wouldn't drink, she wouldn't take meds, and she wouldn't talk to anybody, and she looked terrified. And what I came to realize from working with Billy was that doctors and nurses and nursing aides have one fatal flaw. We never fail. We walk into a room, and the first thing we do is we start asking questions. And that's almost all we do all day long. We go from room to room asking people questions. And what I figured out with Billy was terrified. And sort of going back to that, you know, when they have delirium, what you want to do is tell them who they are. So and it had to be really simple with Billy, because she would growl at people. She would like get her hands like this and chase you out of a room. I mean, she looked terrified. And if that had been my mom, I would have been really unhappy for her. So, and she wasn't my mom, and I was still unhappy for her. So what I did was I went in and I said, Billy, I'm Dr. Nash, you're in the hospital, you haven't been well. And I left. And she was actually pretty calm. And so I went back in a little later. I said, Billy, you're in the hospital. You've been moved out of your assisted living temporarily. We're going to try and help. I'm Dr. Nash. And she listened to me. She really couldn't talk. She didn't chase me. She didn't try and bite me. And and I was like, that's great. And then, how do you feel? And then she started screaming, and she tried to hit me. So I was like, okay. So we put signs all over her room. And the signs were for the staff, not for Billy. And they were, don't ask her any questions. We came up with short little scripts. And the staff would come in, and they wouldn't say, do you want to take your medicine? They would hand her a pill and a glass of water. And she knew what to do, and she would do it. And they would talk to her in a calm voice and tell her who she was and who they were. And they would say things like, you look so pretty today, and we really like you, and just sort of very simple, positive things. And this assisted living that she had lived in, it was in a rural area, and it was really great. They actually built her a little private kind of cabin-like thing that just had a bedroom for her. They cared about her. She didn't have any family left. They were her family. And we were able to get her to a spot where she could go back there. And so that's what really taught me. Billy taught me how stressful it is to be asked questions when you don't know who you are, where you are, or what's going on. So, blah, blah. So, inappropriate sexual behavior. It is amazing what people call that. So if somebody pulls their pants out to urinate in public, that can be called inappropriate sexual behavior. You know, what the question to ask people is it verbal? Is it threatening, or are they flirting? Is it, you know, are they looking for somebody to hug? Are they holding hands with somebody? One of the weird things in Oregon is that, you know, if you enter a memory care unit, your sexuality is supposed to stop. Everybody in Oregon is assumed legally not to be able to consent to any sort of sexual activity, whether they actually could consent or not. And I don't know, there was a big case from the Midwest recently about a guy whose wife had dementia, and he had sex with her at a nursing home, and he got arrested for rape and put on trial. He was a retired sheriff. I thought it was a tragedy. Fortunately, I don't think he was convicted. But anyway, You know, most people who are labeled as sexually inappropriate are not, but look at it. The first question is always, is it dangerous? And then, is there a social history of it? Is it a pattern? So here's sort of two people. So Tom touched caregivers' breasts when they were doing personal cares with him, when they were taking his pants off. Yes, it was sexual. Yes, they needed to do it. He had very advanced dementia. And then what really was the kicker, he lived in a memory care unit, was he was found undressing while a female peer was asleep in a bed in the room across the hall from his room. What did that mean? Well, I don't know what it meant, right? He could have been lost. He lived in a memory care unit. He had dementia. He actually wasn't like doing anything. He wasn't in her bed. He was changing clothes to go to bed. It was nighttime. But that was labeled predatory sexual behavior. And then there was Pete. So Pete, Tom and Pete. So Pete, he was urinating in all of the plants throughout the facility. And he also, obviously, to do that, he had to, you know, expose certain parts of his body. So he got referred for inappropriate sexual behavior. Well, so where I come from, that is actually goal-directed appropriate behavior. He found a pot to piss in. So I'm a big fan of finding the appropriate label. So, you know, what is non-predatory, disinhibited? Well, so kissing an appropriate person, maybe holding hands with somebody and walking with them. And then when your spouse comes to visit and sees you holding hands with some other person, you know, that can be distressing, but distressing to you as the spouse. But if the two people seem to be happy about it, you know, you really have to be careful before you try and intervene there. Because, you know, when somebody's holding hands with their girlfriend or boyfriend and you try and separate them, most people don't take kindly to that. Masturbating in public, sure, it's sexual, it's disinhibited, but is it like predatory? Disrobing in public, urinating in garbage cans. Possible interventions, so redirect them. Consider the use of a one-piece outfit that is a restraint, has to be carefully documented. When might that make sense? Well, that might make sense when you've done everything else and the only way to keep somebody from undressing so that they can participate in social activities, that might be a time to consider it. And then really it's a quality of life intervention. You still have to work carefully because it is restraint. If, you know, the zip up the back. Toileting schedule works wonders. Yes?
What if that you would know all the time that off and on,
So then you sort of have a list of interventions and you go through them every time it happens. You try and redirect them. You take them into the bathroom. You, I mean, usually in somebody with dementia, when they're disrobing, it's because they're hot or because they have to go to the bathroom. Those are the most common reasons, and so that's the kind of thing that you try and address. But, you know, every situation is individual, so I can't really give you a sort of a blanket.
yeah, and this, they know what the bathroom is, they constantly go into the bathroom, so that is okay, but it's the, like, it happened, like today, and I come in and they know they're like hot, when they're still, and I just say, okay, this is not appropriate. Do it over there.
And you just have to keep doing it. I mean, there's, you know, the only, again, it's sort of like, I mean, yes, you can lock people up. You could put them in physical restraints. I don't recommend it, but you constant redirection, which is why shift work is good. So, which medications are the most dangerous for older adults? Well, warfarin, blood thinners, aspirin, insulin, diabetes meds. I always like to put that in because everybody always thinks psychiatric medicines are the most dangerous. Well, it's just unabashedly, documentedly not true. They are not this. So, medications for agitation. Well, here was a pretty large study. There aren't medicines that help agitation. Okay, good to know. But you already knew that, right? Because I already talked about that earlier. So risperidone, haloperidol for treating aggression, paranoia, delusions. Yes, they work. Sometimes they have side effects. Lots of studies. This is just a few of them. Haloperidol or Haldol is an older antipsychotic, has lots of EPS. I'm not a big fan of it as a first choice. I never use it as a first choice in an old person, maybe in a young person. You have to watch for problems. There was a big, KDAD was a study that came out in 2006, I believe. And it was quite disappointing because what they looked at, it was time to discontinuation. So they didn't actually look at whether the medicines were effective. And so I was very irritated that they spent multi-million dollars of taxpayers' money and didn't look at a clinically meaningful outcome. So, but then they went back and looked at the data and looked for clinically meaningful and so then I was happier. So here you can see the yellow line is placebo. And what you can see is that placebos didn't actually help very much. They didn't help hostility, suspiciousness. They certainly didn't help psychomotor agitation. They didn't help psychosis so much. So if you look at the blue line, that's risperidone. And that seemed to help the most. It helped with hostility, suspiciousness, paranoia. It helped with psychosis. Not so much with withdrawn depression. Well, I wouldn't really expect an antipsychotic to help too much with withdrawn depression. Turns out nothing really helped with that. But so antipsychotics do work. They work for some people. They don't work for everybody. They work for certain symptoms, specifically hallucinations, delusions, paranoia, and severe aggression, much of the time, which is caused by one of those above things. So what happens if you have somebody who's on risperidone, which was working for their behavior disturbance, and then you stop it? Well, it turns out most of those people will relapse. Now, I'm not saying you should never try and stop it, but what I'm telling you is if it worked for them and you stop it, because what was causing the problem was their brain, and their brain isn't better. If anything, it's worse. Those symptoms are quite likely to come back. And here are typical doses that I use when I'm using antipsychotics to treat paranoia, psychosis, delusions, hallucinations, and aggression. Risperidone is the best studied. It has the best dosage range documented. 0.5 to 1 milligram twice a day is the best range for the vast majority of people who have dementia. You have to watch out for Parkinsonian type side effects. Ziprazidone, or Geodon is the other name for that. It's a BID. You have to take it twice a day with food, but it tends to have very few of those Parkinsonian type side effects. Olanzapine or Zyprexa can be used. It's a once daily medicine, which is a big plus. There are some complex pharmacological reasons why it's not very helpful at doses above 10 milligrams in people who have dementia. Aripiprazole has the next most evidence next to risperidone. Risperidone and aripiprazole have the best evidence and the largest evidence base. In general, medication, quetiapine is not useful for treating psychosis in older adults. Quetiapine, which is otherwise known as Seroquel, who have dementia and behavior disturbance, dementia, and psychosis. You really need high doses of it. The one exception would be Parkinson's disease and Lewy body dementia. So the FDA put a warning on these medicines saying that they increase mortality in the elderly dementia population. They did that in 2004 on risperidone, 2005 on all antipsychotics, all atypical antipsychotics, the new ones, and then in 2007 on the old ones. So what happened after they did that was people used these medicines a lot less. And these medicines are, I would definitely agree, misused. If you're not used, people use them for wandering, they use them for sleep. And we already reviewed, do medications help wandering? Are antipsychotics likely to help sleep? No. So, Jeff Merkley got me a phone conversation with the medical director, the psychiatric medical director and associate medical director at the FDA in 2012. And they had somebody else on the phone who I'm sure took notes. They didn't tell me they were recording the conversation, so they probably didn't. And so so I talked to them and I said, hey, you know, when the FDA puts a warning out, they have a very nice thing that they do. They publish all of the data that they used to base the warning on. And for this particular warning, it was several dozen studies. And I went and I read every single thing that they were using for their thing, and so for their warnings. And I was really upset because people won't use these medicines in appropriate situations a lot of times. And that's what leads to really injuries and bad outcomes. So I said to them, for clarification, that data that you used this warning for, that data wasn't of people who had psychosis or aggression and dementia. And they said, you're right. And they said it was just sort of generic behavior disturbance and whatever that means to people, which includes agitation. And so I said, well, that's not great. That's a real problem. And they said, we don't care what you think. Then I said, when I read that data, one of the things I noticed was many, many hospice patients are on Haldol. Almost everybody has it at least as a PRN. Terminal delirium occurs in almost everybody who's on hospice. They are almost always treated with an antipsychotic appropriately as part of their end-of-life care. And I said, from looking at the data that you used for your warning, it seems to me quite clear you didn't exclude any of these hospice patients who are almost always older, who are almost always on an antipsychotic. And they said, you're right. I said, well, that's a problem. People who are in hospice die. It's not unexpected. And then they said, risks, which I could also see because I can read. They said, well, you know, risk is really highest in the first 30 days after you use a medicine. And then they said, our theory is because of excess sedation. So they even missed the whole what the literature supports, which is Parkinsonian side effects. So it isn't sedation, because the newer antipsychotics aren't actually that sedating for most people. So, and then Dr. Loughran had the audacity to say, well, you know, it's not a contraindication. My mother has Alzheimer's, and she's on a low dose of risperidone. And I said, with all due respect, Dr. Loughran, it's not that I don't care about your mother. But it's about, there are millions of people who have dementia, and many hundreds of thousands of them would benefit from being on an appropriate low dose of an appropriate antipsychotic for an appropriate indication. And people read your warning, and they misinterpret it. And I said, I really would like to strongly suggest that you look at how you word things, because people misinterpret it. And they didn't exactly say they don't care, but more or less that's what they said. So one of the things that they did say to me, there's no evidence that typical antipsychotics have more risk than atypicals. And that's just, I mean, it's just patently false. I mean, you can see it in your practice, and the evidence base actually supports that there is a difference. So, you know, so I just put a couple things in here that showed there's not a lot of risk. There's significant evidence that the older antipsychotics have more risk. Risk of ischemic stroke. This was 71,000 people, so it's not exactly small. And they looked at risk. And here's what they found. So risk for ischemic stroke, for the most common kind of stroke. So chlorpromazine, which is the oldest antipsychotic on the planet, was the most risky. Risperidone was far less risky. Olanzapine was less risky, right? So, no, that's olanzapine there, risperidone, quetiapine. So the newer antipsychotics are all down here, and the old antipsychotics are all up here. There's lots of evidence. I don't know where they get this. There's no evidence. But it really is begging the question. And here's what I will tell you from my chair. This is the question. What do you care about for your loved one who has moderate to severe dementia? Do you care about how long they live in their demented state? Or do you care about the quality of their life while they're alive? And I can tell you that I am quite biased. What I care about is the quality of their life. And so, blah, blah, blah. Okay. So here was a study looking at what medicines were the most dangerous. So this was done by a group. Dr. Hubricks and her group are up at Harvard. And her group, she really thought, based on the FDA warnings and the order that they came out in, she thought that atypical antipsychotics were the most dangerous meds for older adults. And this is not an uncommonly held belief. In fact, it's a commonly held belief. So she went and looked at this large group of people in Canada who were in nursing homes who were older. And she looked at the risks of atypical antipsychotics versus older or conventional antipsychotics versus antidepressants versus benzodiazepines. And what did she find? Well, of those four classes of medicines, atypical antipsychotics were safer. They were less likely to be associated with death, femur fracture, heart failure, pneumonia. They are not the most dangerous medicines. So even if you're going to get all the blah, 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 you know, people throw lorazepam around like it's water sometimes. But they won't prescribe an antipsychotic where it's indicated. And here's for people who do better with pictures. Here's the same information. See that dark line there? That's the atypicals. So I have sort of an algorithm that I use for treating behavior disturbance. Assess for the type of dementia, assess for functional status, always use behavioral strategies, always look at the caregivers and the environment. Dementia-specific medications have minimal risk and moderate efficacy. Monitor for delirium, where you find it, treat it, look for pain, look for dehydration, make sure people are peeing and pooping. It turns out it does matter. Get rid of harmful medicines. If they're depressed, like they have a history of major depressive disorder, they have anhedonia, they have sort of multiple symptoms suggesting a depressive illness, you might want to consider an antidepressant. If they're manic-like, you might want to trial a mood stabilizer like valproate or Depakote. If they're paranoid, delusional, fearful, or severely aggressive, consider an antipsychotic. Consider scheduled pain medicine. If they're restless, do they have akathisia, severe restlessness? The most common cause of that in older adults is antidepressant. The second most common cause, if it's a medicine, is antipsychotics. Sometimes it's just coming from the brain. You can get akathisia not from a medicine. Pain also causes it. If they're calling out, consider pain. If they're having repetitive questions, buy your staff Starbucks cards and chocolate. If they're wandering, secure the environment. If they're up at night, the best thing to do, rather than a sleep medicine, is to have a little area to direct people to who are up at night, where there's some cookies, something to drink, and something to do. And then, you know, if they look like they're starting to get tired, send them back to bed. That's much better than a medicine. Much more likely to be effective. And then I just have sort of saying the same thing. And this is in your... So Parkinson's disease, Lewy body dementia, memantine, cholinesterase inhibitor. If they're depressed, you want to use a medicine that works on norepinephrine or dopamine. So bupropion or Wellbutrin or nortriptyline. If they have restless leg syndrome, you know, dopaminergic agents, you could consider clonazepam, which I recognize as a benzodiazepine. If they have agitation or aggression, you could consider, after you do all the other things, you could consider some Depakote or valproate. You could consider an antidepressant. You want to treat pain, constipation, urinary retention. Frontotemporal lobe dementia, frontotemporal dementia, there's not a lot medication-wise that has good evidence. There's some evidence that serotonergic medications may help. Inappropriate sexual behaviors. Well, most of the time that's not what it is, so make sure you get a good definition. Help people reframe, use different language. You do want to lower dopaminergic medications. So certain things lead to sexually disinhibited and even somewhat inappropriate action. And so like Parkinson's medicines, for instance, they can lead to gambling behaviors, they can lead to excess sexual behaviors. Mania can lead to that. So, and then here's just some evidence. So this is unpublished, so one should always be slightly suspicious of unpublished data. It's my data, so I feel pretty confident in it. We looked at caregiver burden at admission and discharge on certain things. And we at Tuality, you did basically all the things that I just went over is all of what we did. And so you can see that there was improvement. And most notably, the biggest area of improvement was aggression and psychomotor agitation. There was improvement in disinhibition, irritability. And then if you look at symptom severity, right, so the first one was caregiver distress, which has to do with the people around the person with dementia. This is symptom severity, so that's our best guess about how much distress the person is suffering from these things. And, so these things help. So you have been very, very patient. Nobody looks deceased. That's the first positive. Second positive is everybody looks like they're awake. So if you aren't, you're faking it very well. And the third is we have about 10 minutes left for questions.
And I don't know if this is something that's too broad of a question, but I am curious regarding dementia and differentiating TBI. I saw on there, TBI being one. But I see that.
So TBI, traumatic brain injury. So traumatic brain injury, sort of by definition, means part of your brain is injured, usually by blows. The thing about that is the behavior disturbance you see, the symptoms and signs that you see really are very specific to what parts of the brain were injured. So it's not an illness like Alzheimer's disease and Lewy body disease have parts of the brain that are affected by the disease state, and there's a specific order of brain cell death, and there's a specific order of symptom progression, that more or less everybody who has the illness follows. TBI is different, right? It causes brain damage, can cause behavioral disturbance, and sort of the treatment algorithms that you would use for people with TBI is different than what I've presented here. And it really, the problems that people with TBIs have are being caused by something different than a specific illness. And so you have to actually, you have to know about what part of the brain is damaged. You have to know about how to work with that. So that's a whole different talk. It's a great question.
Do you have advice for caregivers to approach a doctor?
So the question was, do I have advice on how to approach doctors?
I mean, you see people on Seroquel and benzos all the time.
Yes. And I have too. So, actually, the Alzheimer's Association has in Portland has a McGinty lecture, and I did give a talk this last year with a friend of mine whose mother had Alzheimer's, and we gave a talk where I acted as as the family member, and she acted as the physician. And so then we did some role playing, and then we talked about various strategies. You know, physicians and nurse practitioners and PAs are sort of an interesting group of people who are operate under sort of unbelievable time constraints, and sometimes they don't do well with advice. Of course, there are a lot of people who don't do well with advice. But so what I said, that's part of the reason why in the packets, the articles that I put really are directed at physicians, right? So, I mean, they're, especially the one on the Canadian guidelines for treating dementia and the European neurology, European Association of Neurology, or what, EAN. So those two articles really are direct. They're about medicines. They're directed at physicians, and they don't totally overlap with what I've said, but there's like a 95% overlap. Which, for the record, we were doing this before those things were published. But so, you know, I think the best way to help a physician or a prescriber is to give them a specific example of the symptom, not a label, and and sometimes, depending, you have to know. So some people do well if you give them a specific suggestion of what might help, and then give them a reference. And so one of the ways, I will tell you, having been on the other end of this, it is amazing the number of people who fax to me, Joe hit Mary. Then they put a yes/no box, and they put lorazepam 0.5 milligrams Q6 hours PRN. And then a signature line. It was amazing how many, and I never signed those with a yes. I would sign those with a no, and then I would say, send me behavior logs and tell me what was happening before Joe hit Mary. And, you know, and I need their whole med list, you know, but I was a salaried person at Tuality, and I could take the time to do that, even on patients I didn't know very well. And so it's a whole different world. But this is not, these are the current guidelines. And so, but be specific about what it is you're looking for, and give them the evidence. And for many, many providers, that will help motivate behavior. The other thing is work with their office staff. And, you know, and food works not just for people with dementia. Chocolate chip cookies.
Do you tend to discontinue medications like Dimentia and Aricept as the disease progresses if somebody's in more?
Great question. Do I tend to discontinue dementia-specific medicine as the disease progresses? And as you might have picked up from my slides and my presentation, I do not. As the disease progresses, behavior disturbance becomes more common, psychosis becomes more common, aggression becomes more common. So those are the times when you need it more, not less.
Is there a medical reason why the doctors do it then?
The doctors do it because the old evidence told them to do it. And there are even the American Geriatric Society says you should question it. So there's a lot of stuff based on really old evidence prior to 2012 that told people to do that. So that's one of the reasons they do it. These medicines cost money. That's another reason that they do it. And the third is they think of a lot of people, these dementia-specific medicines, when they first came out, everybody talked about them as helping cognitive symptoms like memory. They don't help that in most people, and when they do help, they don't help a lot. But what they help is the behavioral, and those medicines they weren't advertised like that. They weren't studied for that when they first came out, and people who don't treat behaviors for a living aren't familiar with the literature.
Is there new evidence that supports what you're saying?
There is, and it's in your packet. And there's references, all those articles like the Canadian guidelines, there's references for all of their recommendations. And my slides also have some of that. I mean, there's a lot of evidence. It is not actually subtle, but there's a lot of prejudice and fearfulness around dementia. You know, dementia is like cancer was in the 1960s. There's probably nobody here who was like practicing in the 1960s. But you know, in the 1960s, we didn't have any treatments for cancer. We often didn't know what kind of cancer people had. And we didn't tell people when they had it, as if they didn't know, right? They've lost 50 pounds and their brain isn't working anymore, as if they didn't know that they were dying. But we didn't tell people they were dying. And families told you not to tell their loved ones. And that's really where dementia is today. I mean, we are like 50 years behind the times. People are afraid of dementia, and there's so much affect about it. And I think it's hard to think about it sometimes if you don't have a lot of time. But that's a personal opinion. Thank you very much for your attention. I really appreciate it.